Good morning, ladies and gentlemen. This is Asha Shahi from the National Insurance Company Dhaman, and I am part of the disease management team. Thank you for joining us today in our webinar, Eye Health Awareness, Preventing and Managing Eye Conditions. Eye conditions can range from common issues like dryness and strain to more serious problems. Many of these conditions develop gradually and may not show obvious symptoms in the early stages. In this session, we will take you on a journey to better understand these conditions and protect your vision. As we move into the webinar, I would like to briefly mention that today's presentation includes clinical imagery that some viewers may find disturbing. These important images are included for illustrative purposes to help improve understanding of the subject matter. Now, please join me in welcoming our speaker, Dr. Omar Rafiq, consultant ophthalmologist at Moorfields Eye Hospital Centre, Abu Dhabi. Dr. Omar specializes in small incision cataract surgery and advanced glaucoma surgery and has more than 15 years of experience in the UK and in the UAE. Please note that you can send your questions through the Q&A chat box anytime during the presentation, and we will allocate at the end 15 minutes to answer your questions. Dr. Omar, welcome. The floor is yours.
Thank you very much. Good morning, everybody, and Assalamu alaikum. Let me see if I can first of all share my screen. So could you let me know, can you see my screen?
Yes, doctor, now we can see your screen.
Perfect. That's lovely. So thank you very much for the kind invitation. I'm very honored to be here. My name is Omar Rafiq. I'm a consultant ophthalmologist here at Moorfields. And what I'm going to do is I'm going to talk to you a bit about eyes, but I'd really like to make it very interactive. If anybody's got any questions or anything you would like to ask as well, in the meantime, please do just give me a shout in the middle, and I will try and answer the questions either as we go along or during the presentation as well. So some of the aims of this session, I'm going to talk to you about dry eyes, which is exceptionally common. There's a bulk of my workload every day that we see, and I'm sure quite a lot of members of the audience listening may suffer from some form or element of dry eyes as well. And a condition that exists as a spectrum that can sometimes link in with dry eyes is meibomian gland dysfunction, also sometimes known as blepharitis. So I'll try and give some top tips and pearls as we go along as well. Some of the
Doctor,
sessions. Yes.
sorry for interrupting, but can you please present in a presenting screen mode?
Is it not showing on that one? Or about now?
Yes, now it's perfect.
Brilliant. Okay, sorry, I do apologize. So yes, so we're going to talk about how to deal with meibomian gland dysfunction, how to deal with dry eyes, the pathophysiology of it, and especially myself as a surgeon, when I see patients, how from a surgical perspective, the operation is well planned well before the actual date of the operation. So one of the key fundamentals for me as a surgeon is looking at the ocular surface of a patient, because if I want to have successful surgery, then I plan it well in advance. And if you've got a patient with quite gritty, sore, uncomfortable eyes, then the success of surgery is sometimes very limited. And we can see that massively now, especially with what we offer in terms of LASIKs and refractive procedures, and especially a lot of the high-end multifocal kind of cataract surgeries that we do for patients as well. And then we'll finally end with some take-home messages. So I kind of call it the what, where, why, and how phenomenon. So what is it? So blepharitis. So it's an itis, it's an inflammation, and patients can sometimes present with a multitude of symptoms, varying degrees. Sometimes it can be very kind of slight, well, it's something that bothers me. It's not fundamental. It just is something on the back of my mind, and it just is bothering me as my day gets along. Or I get the other extreme where patients are really suffering with it, and they've been bothered by it with years of treatments. Multiple different modalities have been taken place. They've seen many different healthcare providers, and they just can't quite get to the bottom of it. And it can be really debilitating as well, with disturbed eyes, uncomfortable eyes, gritty, sore. And especially, for example, in this particular patient as well, that you can see, one eye is kind of red, it's inflamed, it's quite unilateral, but normally a lot of the times. It tends to be some form or other in both eyes, okay? Dry eye is very, very common. It affects a significant amount of the population. We talk about 50 years and older, around about 30%, if not more, but we see it in a lot of young people as well now. And one of the big causes of that is simply the amount of screen time that we have. It was very uncommon for us in clinic to see patients as children to have dry eyes. But now with the excessive use of iPads, and especially now with home learning and, kind of on-screen use is so prevalent. I call it the TikTok phenomenon. So we have kind of, dry eyes that we see really massively. It tends to affect the female population more so than men, and it's more common in the older population as well. And here you can see a picture of a patient with quite significant dry eyes. So this is a patient where we kind of put some fluorescent dye in, which is a staining dye, a drop. And then when we turn the light blue, any significant areas of corneal epithelial damage that you see shine out green. And you can see in this particular patient, there's quite a lot of uptake there. Now, you can imagine if this is what your eye looked like and you walked around, it would affect many things. You'd be uncomfortable. It'd cause you that gritty, sore feeling, very uncomfortable eyes, glare, halos, and you'd kind of get, a real disturbed ocular surface where you're just not comfortable. Imagine looking through that. And the way that I'd explain it is, imagine you're driving your car and you're looking through a windscreen which is dirty. Of course, it's going to affect some kind of your visual. It's going to compromise some of your vision until it's cleaned. So where does it affect and why? So there are many causes. We have ocular surface disease causes, so systemic medications, systemic conditions, such as Sjogren's, where they get a dry eyes, dry mouth, rheumatoid arthritis, patients with diabetes, osteoarthritis, inflammatory conditions such as uveitis or inflammation of the eye. It can be inflammation around in the body as well, systemic inflammation, and that can be caused. Meibomian gland dysfunction, once again. And in this part of the world, our use of air conditioning as well, our use of computer use, certain medications, antidepressants, various of the medications, alcohol, and age. So there are many different signs of, and we'll talk about dry eyes is quite a huge actually spectrum of conditions, and it can be split up into aqueous deficiency, lipid deficiency, meibomian gland deficiency. So what you can see in these images, what happens is we have this poor lipid meaning fatty or oil composition, and then you can get this obstruction of the meibomian glands. And what the meibomian glands are, essentially, if you look at the middle picture there in black and white, just below the eyelids, okay, the eyelashes, we've got these little linear kind of glands on the inside of us. And these are very, very important, okay? There's around about kind of 20 at the top and 10 at the bottom, okay? And what can happen is these oils come up microscopically just beneath the eyelashes. And you can't really see them, but they are crucial. And one thing I explain to my patients is, imagine if you've got, say, for example, you've got oil on your hand or somewhere, then it's not really going to become dry. So what happens is this oil comes out microscopically and it mixes in with the tear films that are produced elsewhere. And they kind of keep the tears on the eye for a lot longer, okay? And what some people find is that they complain of things like styes or chalazions, which is these kind of swellings around the eyelids that we'll see in a short while as well. And in Arabic, I think we call it akis doni. And it can be really bothersome. And I probably see at least 1 or 2 cases of like a chalazion or these styes a day. And so it's very, very common. And we get this at the bottom picture, if you can see this frothy kind of tear film membrane, if you can see it there as well, these like bubbles as well on there. So these are all very subtle signs that we're looking for to kind of diagnose, but also quantify dry eye disease. Now, another thing that we see, which is actually not very common if you don't go looking for it, is something called Demodex. And I'll talk about Demodex in these later slides. But you can see it affects all patients in varying degrees. Like I said, it can be an inflammatory process. It triggers all these red, uncomfortable eyes. Imagine walking around with an eye like this, okay, you'd be very uncomfortable. It's something bothering you. It affects not just the quantity that we can look, but the quality of life is really debilitating. I've really had patients who have been really kind of disturbed with in terms of the symptoms that they get and just how it affects them. It affects them in all manner of forms in terms of how they function on a day-to-day basis. So Demodex is actually a kind of a parasite that's found near these sebaceous kind of oily units, okay? There are two species that are typically found on humans. There are many more species, but the infestation actually remains normally asymptomatic and can have kind of a pathogenic role when it's either really high or, for example, if a patient is immune compromised. So like with a lot of things in life, we carry a lot of bacteria around us or viral kind of things. And our body is normally very good at fighting this. But say, for example, your body is compromised, you're poorly, you're not able to fight that off, then this can sometimes come to the fore as well. And these eggs are kind of, they can be laid in the hair follicles and you can sometimes see them as well. They kind of hatch after a few days and develop into adults in about 7 days. The full life cycle is about 14 days, 2 weeks. Now, they can live in human hair follicles, kept under control. They sometimes don't cause problems, like I mentioned earlier, but you've sometimes got to really go looking for this. As a surgeon, I sometimes have to remind myself that what happens is in patients who you treat constantly and they're not getting better with all the conservative measures, the drops, and the other medications that we are giving them, sometimes you have to actively go looking on the eyelashes as well for this. And there's many different drops we can give, azithromycin drops, so Azita twice a day for a couple of days. It's quite effective. Sometimes oral antibiotics as well. And then a lot of the times we have to physically remove them at the slit lamp on the microscope that you see right behind me with some micro fine forceps as well, because they're just not getting better. And sometimes you may end up pulling some of the lashes with them as well, which tend to grow back. So now with the tear film deficiencies, tears are more complex than people actually imagine. So we have an aqueous layer, a lipid layer, and a mucin layer. So the aqueous layer, what happens is this can cause what we call aqueous deficient dry eye, so inflammatory conditions, neurological patients, say patients who've had a stroke or somebody who's had, say, for example, a Bell's palsy that we took, a facial nerve palsy. I had a patient yesterday and they are not able to fully close their eyelid completely. So that can cause compromise to the cornea, the window part of the eye just behind this. The lipid layer that we mentioned as well with the meibomian glands, with blepharitis, and you get this mucin layer also deficiency. So you can see it's actually quite complex and it's quite intermingled as well. So you have to really kind of understand which aspect that you're trying to treat. And it's not mutually exclusive. Sometimes there's a crossover significantly in different types as well. So this is the Deuce 2 diagnosis of dry eyes. It's a multifactorial disease of ocular surface, which is characterized by a lack of or loss of homeostasis of the tear film. And remember, homeostasis is a very kind of an important concept here. The body is always in homeostasis. And if there's something that disturbs the balance, then sometimes this is where compromise occurs. It's usually accompanied by ocular symptoms, which we'll talk about in a moment. And there's tear film instability. And what happens in this ocular surface inflammation and then subsequent damage, and then you can have these neurosensory abnormalities, which can cause also causative roles. So we'll look at the traditional causes. We can talk about patients who are on glaucoma medications, for example. So I, as a glaucoma surgeon, sometimes I'm giving patients a lot of medications to try and control their glaucoma to stop them from losing vision. But thankfully now we have access to a lot of preservative-free medications, but in the olden days we were limited with what we had. So some of this medication that is necessary to prevent visual loss, but it also causes a lot of red eyes, dry eyes, uncomfortable eyes as well. And then so the age, the environment that we live in, the Sjogren's, the arthritis as well. There's environmental conditions. So for example, computer vision syndrome, the fact that we're always in the air-conditioned environments, our active lifestyle, with also visual tasking. So all day, if you're in the office, you're spending hours on the phone or the screen use, and then we go home and then we're still on the phone as well. And patients with contact lens use as well. And one thing I will quickly put on here, which is not not on the scope of the audience, but for contact lens wearers, some real top tips for my patients with contact lenses. I'm sure there are people in the audience who wear contact lenses, but it's really important you don't, unless they manufacture them specifically for a reason, you don't sleep with lenses in, you don't swim with lenses in, and you don't shower with your lenses in. And I know I can't really see members of the audience, but I'm sure there's going to be some people who are going to frown and probably thinking that they do this, because it's quite common in my patients as well. It's important that we're just using this as an education tool as well, because we sadly see the risk of infection dramatically rise up as well. And then also your wear time of your contact lenses. It's important that you don't put them in right from the morning really till the evening and overuse them as well. Because remember, the material is pretty good, especially with the newer lenses, but it's still a barrier to oxygen permeability of the ocular surface, and therefore it can cause dryness and irritation. And now we have a lot of preservative-free lubricant eye drops, so you can actually put them in with contact lenses. So if anybody's got dry eyes and you've got preservative-free drops and you've got contact lenses in, then you can put those drops in with your lenses in to try and make you feel more comfortable as well. Okay. And then from a surgical aspect as well, you know, kind of imagine what we do as surgeons, we're going into the eye as well. So the incisions are very, very small. But for example, one of the biggest things is with, say, patients who've had LASIK or corneal refractive surgery. Now, there are different ways of doing this, but when we do the LASIK flap, you're essentially cutting the cornea. And the cornea has the biggest kind of nerve plexus anywhere situated in the body. So you can imagine, for example, if you have a small eyelash in your eye, it feels like there's a brick in the eye. It feels significant, and you're really, really uncomfortable. And that's because of the nerve, the corneal nerve plexus. So another way of looking at it is to have pain sometimes is a good thing, because that's why our body's telling us, oh, that's not good. For example, if you touch something hot, your instant reflex is to pull away, because otherwise you would burn yourself. So that's why we have these nerves as well, and many other reasons. But when LASIK is done, for example, you're cutting those nerve plexuses. And so one of the biggest things I see for patients as well after laser surgery, they can sometimes have dry eyes. So for example, if somebody's coming for me for surgery, I'm well optimizing their ocular surface with lubrication and many things well before surgery to try and mitigate that risk as well. And then the other thing that we talked about was our active lifestyle, our visual. So some of the symptoms that patients will be talking about, they might say that, you know, my eyes are burning, or they're tearing all the time, they're stinging. Now, tearing is an interesting one, because I get this a lot from patients, and it's trying to explain to them. They say, well, how do I have dry eyes if my eyes are tearing? And I'll explain it that, like I mentioned earlier, we've got this homeostatic mechanism. So just from the outside here, we've got lacrimal gland, and what happens is the tears are produced and they drain away. And that's why I say, for example, when you're chopping an onion or you're crying, you'll feel that the back of your throat is also, you know, you've got fluid going down. But what I explain to patients is that the tears are flowing at a very steady state, okay? And if you just pull your lower lid down, for example, here, a tear film will only go across and go in a steady state. So like your sink. For example, if you've got a blockage in the sink, the water will come out, or if you have too much excessive fluid coming into the system, then those drops are falling down onto your cheek. They are no good for the ocular surface. They're no good for the eye, because they've not had time to actually nourish the eye and prevent dry eyes. And the reason for that is because there's a dry eye. So what happens is there's an irritation or dry eyes, and it sends a signal to the lacrimal gland to say, turn on the tap, produce tears. So this is what happens. So by turning off that signal is by making sure you're treating the dry eyes, you turn off that signal, and essentially that's what happens. And there are other reasons as well. I would like to make sure in patients that there's no lacrimal blockage, there's no system kind of an error where there's a blockage that's actually causing the problem and the tears can't go down. So there are different reasons. Patients can have this itching, grittiness sensation. They'll feel like there's something in their eye. And a lot of the times they'll feel that in the morning as well, with this kind of what we talk about, the blepharitis. They'll talk about a foreign body sensation, soreness, redness, feel this heaviness of the lids. And they'll feel photophobia essentially means that light sensitivity. You go out into the light or anywhere, you know, especially with the light sources that we have, especially with the kind of LED lights as well. Some of these are really, really bright as well, and can cause kind of significant photophobia. And then some patients will say, I've got this sticky discharge. Sometimes if it's like a conjunctivitis, then they might get like this yellowish green discharge. But a lot of the times they might say, well, I get this stringy whitish kind of thing that's coming out. And that's important because I do try and advocate to my patients. It's as tempting as it is, don't go what we call mucus fishing. Don't go in because you're aggravating the process as well. So it's worth seeing your healthcare provider for that. And one of the bigger things that patients can sometimes complain is just this fatigue, the fatigue of the eyes as well. And I'll come on to some tips later on as to how we can overcome that. So they are the symptoms that patients are talking about. And then there are clinical signs, signs that we see as surgeons on the slit lamp as well when we're examining patients. So we see something called a reduced tear breakup time, and we'll see some pictures in a moment of that. We get this redness, which is hyperemia, and there's conjunctivitis, these little papules or follicles, little kind of lumpy lesions. I'm looking at the meniscus, the tear meniscus. I'm looking at where there's any debris. Remember the earlier picture? We saw that frothy on the bottom little lid. I'm looking at this conjunctiva and the cornea. It's this excessive watering and the staining of the eye. And we put these different drops in to help us to have a look how bad the ocular surface is. We sometimes also see these filaments and these mucus plaques. And a big thing, excuse me a second, it's got to throw. Excuse me. And a big thing that I do look at is the patient's blink malfunction. And I do ask patients, and it's hard for a patient to understand, but if they've got a family member, I'll do ask them that, you know, when the patient's sleeping, are their eyes completely closed or are there slight subtle, that there's a little opening at the bottom? You'll be surprised how common this is. Even in some of my family members, I've seen it. And the patient themselves will not know because they're sleeping. But that's crucial because what will happen is while you're sleeping all night, and especially if I see a little line of dryness at the bottom, that makes me think, okay, hold on, they've got a complete, an incomplete rather, a lid closure here. So that all night they're slightly exposed. And that will make me change my management plan as well to maybe give them a drop in the daytime, but maybe a thicker ointment at nighttime for dry eyes to try and prevent this happening as well. And then you have this blepharitis as well. So tear breakup time is essentially, we put a drop in and we have a look. So once you've blinked, we ask them to look straight, not to blink. And we're looking at the corneal surface. And it's looking at from when you've blinked, at what point the first kind of dryness starts. And you can see it right in front of you, okay? And we're looking at normal between 10 and 12 seconds. And the quantification, and I'm literally watching them blink, open, don't blink, and I'm just counting down. You'll be surprised sometimes. This is what the tear breakup time is. So you can see where the arrows point to, okay? That's basically where the patient's blinked. And I'll show you in further screens here. This is immediately blinked, and this is at 0 seconds. At 5 seconds, so you can start seeing here, it's starting to break up, okay? And around about 16 seconds, it's worse. So already this patient has a tear breakup time that is reduced significantly, around about 50%. So these are kind of clues that we'll have a look for as well, because it's not just the fact that they are dry, but you know, we know that there's dry, but what's the quality of the tear film? How dry are they? And these are the kind of different harmful effects that you can find. You know, patients have got ocular dysfunction, discomfort. They've got this conjunctiva, which is the lining of the eye, what we call the white of the eye. It's inflamed and red. And I get patients who constantly come, and sometimes they'll say, look, please do something, because my colleagues are constantly asking, what's wrong with your eye? Or they'll say, you know, sometimes, especially my UK patients, they'll be like, my colleagues are saying, you know, have you been drinking last night? Or are you on medication? Or what's going on? Have you had an infection? And it can be very unnerving for a patient to have a red eye walking around as well. And you can get these corneal surface impairments. You get these chronic epithelial changes. If you look to this picture here on your left at the top, imagine walking around with that, because they've got this scarring and this white scar. This will significantly affect a patient's not only comfort, but visual compromise. They will be really significantly affected with their visual disturbance on that as well. So how do you treat it? Okay. So there are many, there's a spectrum of different ways of treating them as well. And it's quite simple, but it's kind of a lifelong thing. And the way that I explain it to patients is it's a bit like, imagine you've brushed your teeth and you've got very nice, healthy teeth, would you stop brushing your teeth? No, you wouldn't. You'd want to constantly continue to make sure you've got maintenance. So initially you may need to do a little more, but you would still try and advocate, brushing your teeth twice a day. So it's just to try and give you an analogy, okay? And same with dry eyes and hot compressors and blepharitis that we'll talk about, okay? Yes, there are sometimes very, very severe cases that we may need to, for example, give antibiotics and do various different things as well. But there are a lot of the times, and the way I explain it to my patients is dry eyes or blepharitis or ocular surface disease is actually a spectrum of conditions. So patients come and they have this mountain of a condition, a real big condition. And I say to them, well, actually, let's break it down into something more manageable. It's actually lots of little things that are adding up. So, for example, we'll talk to them about, make sure you put your drops in, okay? We'll talk to them about try and minimize smoking, if not stopping as well, optimizing their diabetic control, making sure they put the drops in, and also something very simple, and I will give some pointers here, and I was going to say take home messages, but we'll do it as we go along. A real simple but powerful tool that I talk to my patients about is something called the 20-20-20 rule. And I'm sure many of you have heard it before, and I'm hoping some of you practice this as well. Because I'll give you an example. We blink spontaneously. We don't have to think we do it, just like we breathe. We blink maybe every 5-6 seconds, okay? And here's an experiment for you guys, okay? And you're probably going to go and do it, I'm sure. Go home tonight and just look at somebody just paying attention to their phone. So they drops on their phone or their iPad and just count. And just watch and just count how long it takes for them to blink. And I've done this in my little boy and counted about 20 seconds, and it's very common. Okay, so you imagine now where 5 seconds is of your blink rate and where's 20 seconds. It's a 400% reduction in your blink rate. And why do we blink? As we've mentioned earlier, to kind of compromise, make sure that the ocular surface is not compromised. We're providing nourishment to the cornea, to the eye, to the window part of the eye that we see, and to stop dry eyes and many things. And another thing that happens is patients towards the end of the day, because now all our life is fixated with screens and computers and iPads and mobiles. Imagine what happens with any muscle that we overutilize. Any muscle that we overutilize will get tired. Just like say you go to the gym or you're running, you'll have to take a rest period. But interestingly with the eyes, I'm not sure if you can also see me, but your two eyes, your right and your left eye, we've got 6 little muscles on each eye. Okay, so looking up, down, left, right, and then 2 to turn in and out, okay, microscopically. Now, interestingly, your near activities when you're on the computer, your iPad, you're reading your book or your phone or any near activities, you've got one little muscle on your right eye that's contracted and pulled in, and one on your left eye. And now you imagine, relative to that eye, you think your eye's small, but the muscle's even smaller, but it's very strong. And what you're doing is you're now fixating that for near activities for an hour, 2, 3, 4 at a time. What do you think is going to happen? Of course, you're going to get these symptoms of uncomfortable nature, this discomfort. You're going to feel kind of, especially towards the end of the day. And that's exactly what happens. And this is where the 20-20-20 rule is so powerful. It sounds so simple, but it's exceptionally powerful. And to keep it brief, 20-20-20 means every 20-30 minutes of using your screen use, all you need to do is try and look 20 feet in the distance, because by looking 20 feet or 6 meters, your two eyes are in the neutral position. So your muscles are in the relaxed phase. And preferably, so either look through a window, say, for example, even if I don't have a window, I'm pretending I'm looking straight. And ideally, if you can imagine while you're looking straight, just try and close your eyes 20 seconds. And that's how simple it is. And it will really give you a big relief as well. And if you constantly do it as well. And I've got tons of patients who come back and they say it really works. And it does, because I do it myself. And it's very, very common, because these are little top tips that you'll have to, I hope you take home and kind of pass the message on as well, because this is, kind of the way that the future is going, especially with the way that all the kind of jobs are going. Even me as a surgeon, I'll put my drops in between, because you can imagine for a certain amount of time, my eyes are fixated on the microscope when I'm operating. So I'll make sure in between every patient, I'll try and put my dry eye drops in, because while I'm concentrating operating, whether that's a 5-minute operation or whether that's an hour-long operation, I know that I'm so fixated as to what I'm doing then my blink rate goes down as well. So it's trying to take certain things in precaution. Now, omega-3 is an interesting one. Okay. I'm a big fan of omega-3, and there is a lot more research coming out now as well. There are different forms of omega-3 as well. Now, yes, you can take tablets, but I always try and advocate that if you can do things naturally, it's far better. So I try and tell my patients, advocate, try and increase your intake of oily fish, so salmon, your mackerels, your herring, your tuna, chia seeds, flax seeds. If you can't, and you're not a fish person, or you're vegetarian, then maybe you'll have to take something over the counter, cod liver oil. But there are some simple things that you can do now that can preserve your ocular surface and optimize it for the long term. And then you've got lubricant drop use as well. These lubrication drops, a lot of them now the vast majority of them are preservative free. And I've been using them for over a decade as well, personally. And they are very helpful. So sometimes I might just put them in every hour if I'm really struggling, and some days I'll put them in a couple of times a day. So I'll gauge it. But some of the symptoms that I notice will be same: glare, blur, halos. Especially you might notice when you're driving at nighttime, because if your ocular surface is dry, it refracts about 2/3 of the visual potential. And then, as I mentioned, we've got gels and ointments for nighttime use as well. And that's important because it can last a lot longer. Obviously, patients are not going to wake up in the middle of the night to put their drops in, but especially in those patients I mentioned earlier who may have that slight lid opening. So this is quite important. And if anybody in the audience is putting gels or ointments in, I do get a lot of patients who don't like them. And I found out why. And the only reason was because I put them in once. And it's if you put them in straight away, when you go to sleep, what happens is your eyelashes get stuck together. And so patients don't like that. They are very helpful, but they are stuck together, so they don't like it. And a little top tip that I found by trying myself was actually if you put the ointment in, so pull down, put the ointment in, and don't sleep straight away, maybe after 10 minutes of blinking or doing what you need to do, then just get a little Kleenex tissue and just wipe the excess from your eyelashes. And I found that one thing made a massive difference to me, and I tell to my patients as well. And then after that, they find that they are much, much more better, and it really helps them as well. So patient self-care, a lot of this is actually, empowering our patients, it's educating them. So while I'm consulting with my patients, I'll try and show them videos and diagrams and pictures, because it's all good and well saying to the patients, here, this is your problem, use these drops. But I think empowerment is key. Once somebody can understand what it is that you're trying to advocate, what it is that you're trying to explain to them with pictures, and a picture paints 1,000 words. I can have a picture of a hot compress, or I can have an eyelid anatomy and show them why the hot compress works, why a cold compress might work differently in the morning. It's the penny drop moment. And once you've empowered your patients and they have engaged with you, it's surprising how much they really will kind of try and optimize their own ocular surface as well. And it's a long-term condition. I kind of do tell my patients, and it's very powerful. When I, as a patient, will say to them, look, if you use your drops, I've been using them for over 10 years, and then they'll be very surprised. And they'll be like, you, doc, as well? And I'll say the same. Yeah, we also use phones and mobiles and iPads, so we're just as human as you guys are. And it's about increasing the awareness and also demonstration of techniques. Very commonly, kind of trying to tell them little tips as to how to put drops in or how to do these certain things as well. Now, I'll talk a certain about other things as well. Okay, some of you may have, not sure if you've been patients with this, but cyclosporine, okay, so there's a systemic medication which is very strong for certain things, but there's an eye drop version as well, and I'm a huge fan of this. This has really made a massive difference to my patients and my practice, and it's been really, really good the way that it works. It's not an eye drop, it is an eye drop, but it's not something for just simply dry eyes. It works in a very specific way, and it's a chronic process. For example, a lubrication eye drop you put in and temporarily very quickly will work, and then its effect wears off. This is kind of twice a day dosing for a minimum of 3 months, but it's been a game changer. It really kind of helps the ocular surface, the dryness. It's like an immune mediated change that occurs. And then in some very bad cases, we may need the help of some steroid drops as well, or steroid ointments temporarily for a couple of days. With steroids, we advocate just let your eye health professional, prescribe them for an amount of time. Don't just get them from over the counter, because sadly people have used them. They do get you better temporarily, and people have used them for a long time, and that can cause many other problems, cataracts, glaucoma. So you want to have that under the advocation of an eye health professional. And then we've got these IPL treatments as well. There's limited data about IPL. I've used it in the past, initially with kind of big fanfare, but it's dubious as to how much difference long-term it makes. LipiFlow is very interesting. And it's for certain patients who are really kind of not responding to a lot of medication that we're giving. And I've had quite a few patients. It's this procedure here on the left where what happens is essentially, I will advocate patients do the hot compress and various things, but if they can't find beneficial treatment, then LipiFlow has given them sustained release for many, many months as well. And it's something that we have here at Moorfields and other places around in the region as well. So that's the treatment that we talked about in terms of lubricant drops use. Preservative free. So preservatives are very interesting. Okay, so we have different preservatives. So benzalkonium, for example. And the way that I explain it in the olden days, the way preservatives work is for a drop to work in, what preservatives were doing was deliberately causing damage on the ocular surface, microscopic damage, and then the actual medicine was going in. So it was helping in different ways, but preservatives were causing burdensome problems, red eyes, irritated eyes, very, very discomfort for the patient. Okay. And as a glaucoma surgeon, a lot of them, thankfully, it's changing now where I have a lot of access to preservative-free medication. But in the past, we were stuck. We had no other choice. And so, yes, it was good treating a patient and making sure that we could get their pressure down and control their visual, kind of acuity, and making sure that they don't lose vision. But then you have to have that balance in terms of, yes, the quantity of the pressure is good, but what about the quality of life? I can, sometimes there's these images where we have these patients who have got perfect pressure, and but they're not losing any more, causing any more damage to the back of the eye because of the glaucoma is under control. But the patient is miserable, and they have red eyes, and they're uncomfortable, and the quality of life is horrendous. So we really have to see the patient holistically as well, making sure that we can treat everything. And there are differing strengths for kind of certain medication, and some people will prefer kind of very thin kind of lubricant drops. And me personally, I want something thicker that will last a bit longer. So thankfully, we're in a day and age where we have a huge variety available to us. And what's good for one person is not good for another. I can use many different lubrication drops and I'm fine, but I've got patients who will specifically prefer one as well. So patients can be resistant to treatment, okay. We can also have patients who have got multiple drop options with little or very no effect, zero effect. And then you get these real severe conditions where they are moderate to severe punctate staining that's not relieved by lubrication. And in the past in the UK, thankfully here now with the advent of where I was talking about cyclosporin eye drops, it's been a game changer in my practice. But in the UK, we used to have patients with severe conditions that what we had to do was actually take a pint of their blood, send it to the lab, spin it off. And what we used to bring off was lots of drops called autologous serum. So eye drops were actually made from their constituents of their own blood. And that was very powerful and very effective. But you can imagine it wasn't done, for every patient. It was done for specific patients. But thankfully, that's few and far between now. Now, you can imagine patients who've got such bad dry eyes, they can have this exposure keratopathy. So exposure, basically, where their lids are not closing. So say they've had a facial nerve palsy or they've had a stroke, they can't close their eye. And in the past, we've had to sometimes either tape their lid shut, okay, to protect the eye until it regenerates, the nerve regenerates, and they've got some function back. Or say, for example, in a patient who is in a coma and they can't close their eyes, we've had to literally go and stitch the eyelids shut temporarily, as horrific as it sounds. But we know that chronic exposure leaving that open will destroy the eye, cause an infection, and it'll cause an exposure ulcer, which will just erode through, and that's it, game over. And we also talk about, as I mentioned earlier, contact lens overwear, kind of not responding to conservative treatment. And very commonly, I'll tell my patient, we call it a contact lens holiday, and that's exactly what it means. Give your eyes time to rest. Just try and come off 10 days, 2 weeks of your contact lenses and just help to improve that ocular surface. And then maybe later on when you're better, we can go back onto it tentatively, so you're probably using it for when you need it, okay? And the drops that we mentioned earlier. So as a not only a cataract surgeon, but as a surgeon glaucoma and ocular surface surgeon, why is this important? This is, for me, it's fundamental. So when I'm operating, when I've taken a patient to theatre, that planning has already gone on well before. And the way I explain this is it's like a house. If you don't get the foundations right of the house, you can have the most beautiful house, but it's going to fall over, it's going to have cracks. So the foundations are key here. And empowerment, educating patients is fundamental. So, for example, with a cataract, we see varying degrees of cataracts as well. Patients who can have, poor vision in one eye. Their concerns are exceptionally important because they may not be able to see, but they're also got really bad ocular surface. So it's important to educate them and say, let's treat the ocular surface first, because if I'm about to operate on a patient, yes, it won't change my operation, but the post-operative recovery of a patient is fundamental. Because the risk of infection dramatically shoots up as well. So no patient is going to thank you if you do a beautiful operation and they can't see because they've got a devastating infection that they picked up because they had a poor ocular surface. So it's fundamental, as a surgeon, I'm looking at lots of things, hygiene, fingernails, various things, who's going to put the drops in. So this is key, because patients' concerns can be very different as well. They can have very unhappy patients, red, sore, uncomfortable eyes, fluctuating vision. I get patients who will be like, instantly, literally here in my clinic, I'll put a drop in for them and they'll be like, oh, hold on, I can see better. And that's fundamental because that gives the game away there and then. To me, that's, ocular surface. That's your dry eyes, because what's happening is a drop's gone in and your tear film is now smooth and you can see as well. So these are fundamental kind of things. Now, we talked about, and we always say, look, prevention is better than the cure. And I think that's important because there's a few take-home messages I'll give. I hope you've had some kind of an interesting insight into meibomian gland dysfunction and blepharitis and dry eyes. And one thing that I didn't mention, you saw me put on earlier a picture of an eye bag, okay? And I think one thing I would also like you to take home is how powerful that eye bag actually is. And I'll tell you how you can actually make it as well. You can get them from Amazon and various things, but it's simple. So I get a lot of patients. Now I don't know about yourselves, but maybe in your family. But when I was a child and I had something in my eye, or something was bothering me, I remember as a kid, I remember this very distinctly. And maybe it'll jog your childhood memories as well, running up to my mum and saying something's in my eye. And she used to get like a towel, she used to blow on it and put it on my eye, and it used to give instant healing and, kind of relief. Some of the audience members are smiling, thinking it brings back memories. But there was magic to that, and it makes sense why, because what they were doing was actually, without realizing, they were heating up the eyelids, and those oils were starting to flow. And so, for example, these bean bags and these eye bags, you can get them in different forms. They can be gel bags that you can put in into the freezer, as well as putting them in hot water. So if you've got any inflammation, I tell my patients that in the mornings, try and do a cold compress. So anything like even a bottle of water, put a Kleenex around it or something for a minute or so. That's more than enough. It just dampens things down. But a hot compress at nighttime is so powerful, and it's been a game changer for a lot of my patients. And it's all about explaining to them. So what they'll say is that they've done a hot compress. How have you done it? And they'll say, well, I did a tea bag, or I did a hot towel. The problem is the concept is correct, but it's the amount of time you need. So you need 10 minutes, okay? And we know this by science. And the way I explain it is everything has a different melting point. Chocolate will melt in your hand. Gold you'll need to put in a furnace. So for example, an egg, if you want to boil an egg and you put it in boiling water for a minute, it's still not boiled, it's still not cooked. It's got to be the time. So with a hot compress, if you do a towel or a flannel, the other example I'll give you is, for example, if you go on an airplane and they come around with the hot towel, okay, that's really warm, but it'll stay warm for what, 30 seconds, 60 seconds, and then it's cold again. So that's the key. You need constant maintenance for 10 minutes. So how do you do it? And it's that simple bean bag, okay? And you can actually make this at home. It's so simple and it's so powerful as well. All you need is a cotton sock, make sure it's brand new, and fill it with just uncooked rice, raw rice, any rice, doesn't have to be anything, flax seeds, whatever it is. Make it around about that big so it's sufficient for both eyes. Tie a knot in it, and you've got your bag. And then you can put this in the microwave for about 20 seconds, so not long, okay? Obviously, making sure you're not leaving it unattended. And then you check it on the back of your hand and make sure that it's comfortable and that you can tolerate it. And it's a game changer. It's so lovely. You close your eyes and put it on your eyes for 10 minutes. It'll stay warm. And what that one thing will do is that heat glands that we talked about earlier that are just giving those oils under the eyelashes, they will start warming up. And in the olden days, we used to talk a lot about Johnson's baby shampoo and cleaning your eyelids. Actually, now the evidence is saying that just gets rid of the good stuff as well. So after that, what you do is you just get some warm water and a bit of cotton gauze and just wipe your eyelashes clean side to side. And some patients may say, in the mornings, I wake up and I feel like I've got something in my eye, and then I blink and it goes away. And that's what's happening. Those oils are coming out microscopically. They're sticking to the eyelashes like dandruff, for example. And then they fall into your tear film in the morning when you wake up. And because it's oil, you blink a few times and then they disperse away. So this hot compress, this is phenomenal. It's so simple, but it's so powerful, okay? So these conditions, meibomian gland dysfunction, blepharitis, and dry eyes, it's a syndrome. You don't tend to find one or the other. They tend to work concurrently, okay? Ocular surface health is key to optimizing for me as a surgeon, pre-cataract surgery or pre-glaucoma surgery, any surgery perspective as well, because it affects my result afterwards as well. So these are some of the references. If there are, I would be very happy to go through concepts or something that you think may not have been answered. You've got other questions you want to ask as well. And that's the end of the presentation. I hope you've learned something.
Thank you, Dr. Omar, for the informative presentation on understanding eye conditions. Now we will be moving on to our Q&A segment. So, Doctor, we have our first question is, how can we tell the difference between dry eyes and allergic eye disease?
So very interesting. Okay, and a lot of the times they are here in this part of the world. So, for example, in my UK practice, born and bred in the UK, when I first came to the UAE many years ago, it really took me by surprise. So in my UK practice, maybe when spring, when I used to say when the daffodils, when the flowers are out, we used to see this bad case of kind of pollen and allergic conjunctivitis and people with these dry eyes. But when I came to the UAE, it was like November, December, and I was seeing severe cases of allergic, and it really did confuse me. And I'm thinking, this is not spring. So it's fundamental how even geographically your practice changes. And there's a very simple reason I came, especially the geographic area where we are, the sandy climate, the humidity, the aircon next to the sea. All these things make a big difference. So it's a syndrome that it's not just one or the other. A lot of times you'll find that basically try your dry eye drops, but it's always good to maybe get your eye health professional just to have a look, because there are subtle signs. So yes, dry eye drops may help the ocular surface, but sometimes you'll need certain other medications that can help with your allergic conjunctivitis. And another thing that I ask my patients is, do you have sinusitis? Do you have kind of allergic sinusitis, rhinitis? So these patients are key, because one of the key thing is we've got like sinuses here and they should be air filled. And the way one of the things I ask my patients is, well, say for example, when you bend forward, does it feel heavy or stuffy? And they'll say yes. And the way I'll give an example is, say, for example, you've got this bottle of water, okay? So when you're upright, it should be air-filled, okay? And air-filled pockets, so for resonance and sensation. What will happen is when you go down, imagine the water now, it's pulled down. So if it's filled with gunk and sinus kind of issues, they'll feel that. So that's one of the things. And some simple things that you could do, like, say, for example, Vicks. You'd be surprised. I'm a big believer in the old chronic things. Like I remember once again, my mum, I think my mum should have been a doctor. She knew a lot of stuff that I know now as a surgeon. But Vicks, for example, that we put on kids, bit of Vicks or Olbas oil, put it in some hot water and take some steam baths or something. But I always say a lot of the times I do need the help of my ENT friends and colleagues as well to let them look up the nose, because sometimes it's linked So I need kind of, if patients have got these kind of allergic eye disease, you'll be find a lot of the times it's related to allergic rhinitis, sinusitis. So yes, we will treat the eyes, but I might need the help of my ENT colleagues to have a look as well and treat them systemically, areas, certain other medications as well.
Thank you, Doctor, for the detailed explanation. We have also another question from our audience. What are the chances that children's eyesight improves on its own as they grow? And what age is recommended to consider LASIK or other correction procedures for these kids?
Okay, so with kids, I think here the UAE is a bit different in terms of the market. In my UK practice, it was different. We had a national screening, so any child who approaches school will have orthoptic colleagues going in. So they used to do arbitrary visual measurements. So before they get to a certain age, because with children, what we're absolutely adamant on is to try and see whether there's a problem where we can do something about it. And it's so sad because, for example, if they've got a refractive error, so they need glasses or there's something going on that we need to intervene with, we can get to it early, then we can allow the brain to see. So what we're trying to prevent is a lazy eye, what we call amblyopia. So whether that's a glasses prescription, and you'd be so surprised. Kids are amazing at what they do. They just carry on. And sometimes and I get this, we get this in clinic where patients, parents are devastated because they're like, the child, say 14, and one eye is really bad vision. And they're like, I had no idea. And we say, well, it's not your fault, but this is why we're trying to educate patients that, look, have an annual screening, get to the kids too early. So for example, kind of 3-4 years, at least you'll be surprised. We could even check vision without the child knowing ABC. There are different ways that we could assess visual compromise as well to see, okay, actually, we're a bit more worried about this as well. So screening is absolutely important because if, for example, a 4-year-old, 5-year-old has like a +3 prescription in one eye, you see, what's going to happen is if they've got a prescription that they need treating on the one eye and the other eye is good vision, the brain will try and see, but at some stage, what's going to happen is it's going to give up the ghost and that eye will become lazy. Because the eye, even though it might be healthy in itself, the pathway to the brain needs to see. So if you get to that 7, 8, 9 year of age and it's not seen, then that becomes a lazy eye. Some of the research now tells us we can push it to about 12, but on the whole, we really want to be very aggressive with, say, patching or intervening because we want the eye to actually see what the top level of vision is. So a lot of the times I see patients who are adults and they might see the top letter of the chart in one eye and 20/20 in the other eye. And it's so sad because the eye is completely normal. Just because nobody had got to it, nobody had screened it in time. So make sure you have screening. With LASIK, now LASIK's an interesting one, okay. And it's especially now with it being so prevalent everywhere, people want to get, and I have seen patients who are very young to have had it done. The minimum that we say is 18 years of age, and there's a reason, but also with caveats. We obviously have to test to make sure that the cornea is strong enough, thick enough before we finish. It's going to meet the parameters of what we're going to do, treat the ocular surface. But we're also adamant to make sure that the prescription on the patient's glasses has not changed for about a year. Because if you've got variation in prescription, what am I about to laser? Because if, that's going to change and haram, you've done something that would. So sometimes as a surgeon, you see what we're taught and fundamental to our training is knowing how to operate is the easy part. Knowing when not to and saying no is sometimes the hard part. And it's a challenge because especially I've got a parent who's pushing, no, he wants to be a pilot or he's going into the military. We're like, we understand, but our duty of care is to tell you, no, there's a way, or you're going to have to wait. Like, it is. I've seen a 13-year-old being lasered. Thankfully, this is unheard of now. But my first question was, why and who? But thankfully, I think education is coming out as well. There's a lot of international guidelines that we have, and we adhere to evidence-based medicine. So we're quite lucky at Moorfields. We run kind of an NHS type practice as well, where I have the access to a whole, I've got a corneal problem, I'll speak to my corneal colleague. I've got a retinal problem, I'll speak to my retinal colleague. We work in a multidisciplinary team, and I think that's important as well. So I hope that answers your question.
Yes, understood, doctor. So moving on, doctor. I have had some symptoms before, like twitchy eyelid that comes and goes. So what is the reason for that?
Yeah, so I'm, as well as a surgeon, I'm a pretty good patient myself, which is quite nice when you empower your patients because I have a twitchy eyelid, and I'll tell you, you're going to laugh. Probably members of the audience will laugh as well. So I call it the TikTok phenomenon. So what happens is we go home, and sometimes we're addicted to the phone so much, so you'll even sleep, one head on the pillow, and what will happen is you've got your phone in front of you, and one eye's closed, and the other eye you're scrolling for an hour or two. And then in the morning, you'll wake up and think, why is my eye red and it's uncomfortable and it's twitching? Now, twitching can be many other reasons, certain medication, diabetes, neurological conditions. But for example, I know when mine twitches, it's a sign that my eyes are dry. And it's always this one. I know what I do, and it's self-inflicted. So a lot of the times it may just be the fact that you've got a poor ocular surface, or you've got dry eyes, or you've, like I said, you've been on the phone for such a long time, or the computer. And those pearls that I was mentioning, will pay dividends to people for the rest of their lives. Omega-3, your 20-20-20 advice, putting your dry eye drops in. I say it as though it's a sign from the body to say, look, just stop, something's not quite right. It's a bit like when you're driving a car and your car start moving and you ignore it. It's giving you a warning sign, something is about to happen. So you either address me now or I'm going to address it for you. So sometimes, yes, let somebody see, because twitching could be something else. But a lot of the times it's innocuous. It's quite simple reasons. Either there's allergic eye disease or some dry eye element of it as well. But yeah, a lot of the times those are the kind of symptoms for it.
Noted, doctor. Doctor, moving on, how to know if my eye pressure or intraocular pressure is rising? Because I believe you cannot really feel it, or it has symptoms while happening.
Yeah, so this is an interesting one. So glaucoma, we also call it the silent killer, kind of the silent sight of thief, because what will happen is pressure is an interesting one. What is a good pressure for one patient is not necessarily for another patient. So we have a spectrum of conditions, and I'm looking at family history, the thickness of the cornea, what the optic nerve, what the health of the eye looks like as well. Now, with pressure, you've got to have, imagine now you close your eyes and you just feel it, you'll feel the eyeballs quite softish, okay? So a certain idea you can have, but for example, the only way really is to have it measured in an annual screening. I advocate to all my patients, please make sure you get screened once a year by your high healthcare provider. In the UK, we have a different system where they can go to the opticians in the community. Here, obviously, they come to us, but just making sure your vision is good. There'll be so many things that we pick up on a routine screening exam. For example, are you a diabetic? Maybe it's worthwhile getting screened out, or high blood pressure. We see changes before the patient knows. Or, oh, your pressure's high. Then we start investigating further on as well. So it depends. If it's a glaucoma patient, then depending on the severity, we'll measure that. Some patients I'll need to see every 6 weeks, some people once a year. But it depends and there are now some eye care devices that people can get at home. I wouldn't advocate to get them. The reason being is because what you're going to do with that measurement as well. It's better you see your eye healthcare provider at least once a year to get screened out, where we can do a thorough assessment from front to the back, measure eye pressure, look at the back of the eye, and see what needs to be done from there.
Thank you, doctor, for answering that. And we will be moving on to our final question. Are cataracts only age-related, or can younger people be affected as well by it?
Yeah, so really interesting question. Cataracts can occur for many, many reasons. So I'm an adult cataract surgeon. So my youngest patient is 18, and my oldest patient is 102 that I operated on. So you can see the vastness. Children can be born with cataracts. You can have congenital cataracts. Okay, so they'll be going over to my pediatric ophthalmology colleagues. Trauma, diabetes, infections, inflammations. There are many, many reasons that a cataract can occur. But one of the biggest things is here in this part of the world, and once again, I advocate to my patients, please put your sunglasses on outside, protect your eyes from UV protection, fundamental. A lot of my patients in the UK, we do high volume lists, so we'll have like 25, 30 cataract patients in one day to operate on. And when I get somebody below the age of 50, it's like interesting, probably because there's not much sun outside. In the UK, it's always raining. But most people, my population is elder population based. Here in the UAE, I get a lot of patients in their 40s with cataracts, with no diabetes, no other thing else. And I'll try and tell them, protect your eyes, the sun, exposure, UV exposure. So age, UV exposure, certain medications, steroids. So that's why with steroids, I mentioned earlier, we do use them, but you shouldn't get them over the counter. I had a fascinating case with a young lady once who managed to get, I don't know how, but managed to get steroid. Every time she had a red eye, she used to get steroids. She had no idea it was steroids. She'd been using it for 2 years. And by the time she presented to me, she was pretty much blind with cataracts, glaucoma. It needed aggressive therapy. So thankfully that's been changed because it went up to the Ministry of Health as an advert. But yeah, those are the different reasons cataracts. And once again, just get screened. We'll pick it up, you know.
Understood. So, Doctor, with that, we will wrap up our Q&A session. Thank you once again, Dr. Ammar, for sharing your expertise and valuable insights on such an important topic.
My pleasure. Thank you very much for kindly having me.
And to our audience, we have now reached the end of our webinar. Thank you for joining us and participating. Please take a moment to answer the survey question. Your feedback and input are appreciated. Thank you all for joining us, and we look forward to seeing you all again in our upcoming webinars. Stay safe and enjoy the rest of the day.